All right, good morning or good afternoon, everybody. So welcome to our July lunch and learn training on accidental drug ingestion. I'm really, really excited to have Jen Perry and Adrienne Owen here from the Office of the Child Advocate. So without further ado, I'm actually going to turn it over to both of those ladies, if they don't mind taking a moment just to introduce themselves. So maybe Jen Perry, we'll start with you, and that way we can go into Adrienne. So Jen, how about you get started?
Sure. Good afternoon, everyone. My name is Jen Perry. I am the Deputy Investigation Coordinator. Our office is the Office of the Investigation Coordinator, which falls underneath the Office of the Child Advocate. And basically, our office is tasked to monitor all cases of sex abuse, near death, and sex trafficking of children statewide. We track the case through the civil investigation and the criminal investigation, kind of monitoring how things are going, look at different trends, and we report that back to our Child Protection Accountability Commission. We also facilitate our multidisciplinary team meetings so that when these kinds of cases come in, we bring the team together, do a meeting to make sure everybody's getting that firsthand information, ensure that communication is happening right away. So we are the ones that are facilitating those meetings. So that's pretty much me in a nutshell, and I'll let Adrienne go.
Awesome. Thanks, Jen.
Hey, good afternoon, everybody. I'm Adrienne Owen. I am with OCA as the MDT Policy and Training Specialist. Boy, that is a lot of something to say. I'm kind of the keeper of the MOU, the Child Abuse and Neglect MOU that directs what the system response will be to these suspected cases of abuse and neglect. And by system response, really your DFS and your law enforcement, your prosecutors and your CAC and your medical, well, no more, medical and et cetera. So kind of overseeing that, making sure we keep it updated, and then, working with our frontline to provide training and understanding and consultation with them. Other responsibilities, other trainings, like mandatory reporting trainings, other things here and there, and then somewhat assisting Jen as we work on juvenile trafficking response. So I'll be done talking on that. That's enough about Adrienne Owen. Let's move on to the good material. I'm going to screen share here. Of course, we have the old PowerPoint, which Lord knows we love, but still I use it because most people are going to be learning through listening as well as visual. The majority of us are. So I still stick with this tried and true. Okay, everybody can see the presentation, I hope?
Yep, all good.
Okay. So I'm going to go ahead and start off the first half, and then Jen's going to pick up. So I'm going to talk just basics about how we define, drug ingestion or ingestion, how it happens. Excuse me, a little bit about Delaware data. We collect, sorry about that. We collect, my stuff's very sensitive here, my technology. We collect some data here in Delaware. Obviously, we get a better read on what's happening as we start looking at trends. How those ingestions can occur, and reminders and prevention. So I'm going to cover the first part, as I said, and Jen's going to cover the second part. And before I dive in, my little warning, you can tell already I am a fast talker, just like Jen is, just like Lauren is. So you are bombarded today. I call it data bursting. You're getting data bursting at you. So if I am going too fast, please, I am not offended. If you're like, you got to slow down, Adrienne, you're going to give me a headache. I promise you, I will not be offended. So I try to monitor my pace, but I tend to be fast. It's my nature. So, we had to kind of define in Delaware for our team, our MDT, our multidisciplinary team, our frontline team. We had to define what is a pediatric drug ingestion. And I know I say drug ingestion here, but really it's just ingestion. Ingestion is something that could harm them. So in our MOU, we came up with a definition as a group. And we put in our MOU that it could be that the child has ingested alcohol, that the child has ingested prescription meds that are not intended for them. So someone else in the home, their medication, prescription meds, or even over-the-counter medication that is for the kid, but over the directed dosage, or any illegal drug. That's typically what we think of when we talk about drug ingestion, any illicit substances, or just anything believed to be harmful. What about bleach? Household chemicals, something like that. So it's a really broad range of substances that a child can ingest. But, for the sake of our conversation today, we're going to focus more on drug ingestion, not so much, those harmful substances maybe that a kid has gotten a hold of. Now, how does it happen? So just want to kind of break it down into 3 avenues by which a child can ingest a substance or drug that could be harmful for them. So we look at accidental, negligent, and intentional. I'm not telling you that that's how we lay it out in the MOU, that's how we define it in our MOU, but as a team and as a front line, including our medical, we kind of look at, did it happen accidentally? Did it happen because maybe a parent, they don't do due diligence with a child, or is it even intentionally occurring? So when I say accidental, give you kind of an example. So prescription pill, maybe a tablet or a capsule that's dropped accidentally. You might see situations, or we might see situations where maybe there's multiple people living, 3 generations living in the home, and grandmom is taking her medications, her prescription medications that she's allowed to have, and she drops one, not realizing, on the floor. And then we have a toddler that ends up getting a hold of that. She can't see it, doesn't know it dropped. The toddler gets a hold of it, takes that. That's truly an accidental situation, right? We do have those types of situations occur. And how do we kind of, as frontline responders looking at these cases, how do we help determine? Because it's really, each case is a case by case. We kind of have to look at the totality of the information that we have at hand, and including, as we continue to investigate, more information that we get and absorb. But we're taking all of that to help us come up to the decision or make that conclusion of like, hey, was it accidental? Was it carelessness? So some of the things we look at, are there actually safety measures in the home? When we look at the home and we listen to what the parents or caregivers have to say, are there actually, hold on, I think someone's unmuted. That's probably our feedback reason.
Yep, I think we're good. Sorry about that.
There you go. If we look and we see that there's safety measures in place in the home, like, they're showing us where they store their medications, they're in an appropriate place high up, or they're in a locked cabinet. There's other safety measures in place, even something like that there's firearms in the house because they hunt, but the firearms are in a gun safe, things that demonstrate that they're taking appropriate precautions. Then we're kind of comfortable, and we're thinking, okay, that's probably accidental. Did they show appropriate care, concern for the symptomatic child? Like, oh my gosh, my kid doesn't seem normal. They seem off. They're off in space. I can't keep them awake. They're just acting funny, and they're concerned about it, and they're getting appropriate medical consultation and measures. And maybe that is calling poison control. And then after that, they're taking their kid to the doctor or to the hospital, depending upon, how symptomatic that child is. When we look at those other factors, that helps us determine, okay, that's accidental. With the story also of how that might have happened. Grandmom's like, well, I mean, I was taking my medication last night, and I guess it's possible I dropped one. I try to be careful. Okay, well, that would be a situation again where we'd say, accidental. Negligent type of situation, or a situation with negligence, would be where a prescription medication, illicit substance, drug, or other harmful substance is left unattended and or accessible to those kids. And it is tough, certainly, to create an environment in your home where you foresee every possibility where a kid could get into something. And kids are certainly amazing, little beings that can find their way into anything practically. But for the most part, you can kind of look at an environment and tell, when you look at the totality again of that situation, are they taking some sort of appropriate safety measures in the home? Or do they not have a place where they keep medications? And like, oh, I keep my prescription meds in a basket on the nightstand, and you have a 2-year-old and a 4-year-old and an 8-year-old in the house. Okay, that's not appropriate safety measures, right? Not the best situation. In that scenario, maybe do we find that there's a delay in seeking medical consultation or treatment for the child? That's another indicator. And I'm not questioning. I know sometimes parents are like, well, I don't want to be paranoid and I don't want to jump to conclusions. But if a child is suddenly, again, demonstrating maybe a situation where they're just not responsive, the far off look, you can't keep them awake, or they're acting giddy and ridiculous and odd, dozing off suddenly, things that should prompt you to get immediate consultation. That's when we say, yeah, they shouldn't be delaying. They should be getting appropriate consultation. We also sometimes see that someone in that home may also be engaging themselves in substance misuse. And we know that through their history, a DFS history, as well as and/or criminal history, or, contact with law enforcement based upon substance misuse. Or we just know it based upon conversation with other parties in the home that indicate, this one parent maybe is a substance user. So that would be negligence. They didn't intentionally harm their child, but they certainly aren't using the appropriate care and concern with substances in the home, whether they're prescriptions or they're illegal drugs. They're heroin, they're methadone, something along that, their marijuana, something along those lines. We see obviously a lot of marijuana, which I'll talk about in a second. Intentional, just like it sounds. So this is the situation where the parent or caregiver is giving, whether it's prescription meds, some illicit substance, or alcohol, or a combination thereof, to a kid to often to induce sleep or sedation. Kid doesn't sleep well, kid doesn't rest well, maybe the parent's overwhelmed, a couple of factors, but the parent needs that kid to come right down here, to come way down, to dial it down a little bit. And so we, even if the parent doesn't tell us what has happened, we can kind of figure out something is amiss and maybe this is intentional based upon that, again, that delay in consultation with medical experts, minimizing the child's condition, not even just delaying, but minimizing. Well, it wasn't that bad. And meanwhile, the kid's unconscious. They're like, well, it wasn't that bad. I just thought they were sleepy. I think we can tell the difference between sleepy and unconscious. Even those of us that are laymen without a medical degree. Maybe the parent or caregiver is providing an explanation that just doesn't fit with the child's condition. I just gave them a little bit of, it's a 4-year-old. I just gave them a little bit of melatonin to help them sleep. But meanwhile, that child can't be roused, is really out cold. They claim that other parties, maybe the parent or caregiver, when they're being interviewed or talked with by the frontline DFS and law enforcement, they're claiming that there's other parties that visited the residence in the recent past. Oh, try to take the blame off themselves. So-and-so visited, his sister visited, his cousin visited. I think that might be the issue. Complete deflection of taking responsibility. And caregivers may be seeming exhausted, overwhelmed, or impaired. Looking at those situations when we see those factors, that tells us that maybe it's possible. What are an example? I mean, I know Jen could give 1,000 of them, but from looking at all these cases, but I can tell you from even in the past working these in my last lifetime, sometimes we see parents might crush up a little bit of prescription medication or put a little bit of alcohol in a bottle to feed to the child to try and induce sleep. Right, not realizing that you shouldn't do that, I guess, but thinking that a small amount is going to be okay. But kids process things so much differently, and what's a small amount to an adult is a large amount to a child. So I hope that kind of explains how we look at those. How's that happening? Those drug ingestions, and then that also helps us as frontline, or helps our frontline MDT to decide, what are the next steps going to be. Especially when you're looking at DFS. It does help as far as the criminal aspect of an investigation and what charging might occur. But more importantly, it helps on the civil side of this investigation or this response, and that is with DFS. What is the level of care and concern? What are the amount of measures that need to be in place to help this family? What is the safety plan going to look like? So that's really why we look at that, how we break it down, or why we break that down, and kind of how we use it. Okay, so I want to talk a little bit about just a little bit of data, a couple slides about drug ingestions. I know this seems like a random time frame. It really has to do with how we're data capturing for different projects at OCA. So when you look from December 2016 through April, like spring of 2023, at drug ingestions that our IC office has tracked, you'll see we have 116 cases noted with 200 suspects, because sometimes it's one parent in the home or one caregiver, or it might be 3 adults in the home that could be suspects, with 130 victims. So 116 cases, 130 victims. Why 130 victims? Because we have some cases where we have multiple kids in the home where there's ingestion that occurs. Just a breakdown. I don't think this is probably shocking to any of you. The breakdown on where the occurrence is by county, right? So 50% of them in Newcastle, 32% Kent, 18 Sussex. We typically see that you're going to have half of all of the cases, no matter what type of maltreatment happening to children. Typically around half are going to be in Newcastle County. That's our largest county. And then around an equal distribution, a little bit of variance, but equal distribution between the 2 other counties. Although we typically see an increase in Sussex in general with all types of abuse, just because of population growth. There's an explosion in Sussex County. So the number of drugs ingested in these drug ingestions with 130 children, so 87% of those cases there was one drug that ended up being detected. In 11%, we had 2 drugs that were detected within those children. And then in 2%, you can see there were 3+ drugs. So the majority, it is going to be 1 drug. So in those single drug ingestions, you can see the majority are marijuana. And we follow closely by cocaine and fentanyl. There's some of that Suboxone, some opiates. There are other substances, a few others. So there's just going to be maybe prescriptions, various prescriptions. Sometimes there's blood pressure medications. Sometimes maybe clonidine for mental health, or other prescriptions that are happening in the home for the adults. But obviously, we're concerned about the fentanyl, cocaine, and marijuana, especially the marijuana, not because it has more harm. Fentanyl certainly has more more likelihood of causing significant harm to a kid. But with the marijuana, we're just seeing so much of that in our state, actually around the nation. We're not off from other states. So in those situations, those kiddos that have 2+ drugs that were ingested, you can see here that more commonly, so it's marijuana and fentanyl combination. So the marijuana that has fentanyl in it, the Tylenol and Keppra, so just Tylenol, an everyday substance along with another substance. You can see here the opiates, with the fentanyl mix and xylazine. There's a variety. Nothing's going to stand out here other than the marijuana, but with the fentanyl. The other thing I just want to bring up is that we are seeing a little bit of an increase in that xylazine. It's co-occurring with fentanyl, co-occurring with opiates and fentanyl. Xylazine is a horse tranquilizer. I'm not here to tell you that we're seeing a huge amount of those, but we've seen an odd increase with those. Why do I say that? Just to point out that any type of substance can be ingested. If the adults are trying different substances in an effort to be high, then there's an increase. If we're seeing an increase in adults, the adult usage in our state, then we're going to see somewhat of an increase with our kiddos. So what about fentanyl ingestions? Because again, fentanyl has the possibility to be extremely deadly very easily with a very, very small amount ingested. So just some fentanyl data. Out of these cases, the cases where we saw fentanyl ingestion, the ages of the victims were 0 to 11, and we had 2 sibling groups, actually. So talking about those, remember I said there's 112 cases, but 130 kiddos that we're looking at here. Out of the multiple sibling groups with fentanyl, we have 2 that have sibling groups, 3 victims with marijuana and fentanyl in one sibling group, and then another sibling group, there was just 2 kids, but with the fentanyl. And you see here 58% of those cases were in Newcastle County. Again, not a surprise. The majority of all of these types or maltreatments are going to be in Newcastle County, just because of the population size. We broke it down. So again, 69% are straight fentanyl, but then we have some with clonidine, then we have some fentanyl mixed with that xylazine, with marijuana. We are always gravely concerned, Jen, more so, especially because of her seeing these cases on the regular with fentanyl. Again, it's just such a small amount of fentanyl. It's like a pinhead's worth is deadly for multiple people. It is it's just a dangerous drug. Age, the victim's age at the time of the ingestion, you can see here under 1 year of age, 13. And this is again the 130, not the 112 cases, but the victims, looking at the number of victims. We had 130 we're giving you in this bit of data. So 13 of them were under the age of 1, 33 at the age of 1. You can see here 17 at the age of 2, and then we're at 18, 17. So what's your takeaway? Look at the drop down between 4 and 5. We see them at all ages, these ingestion cases, but the majority are these young kiddos.
I was going to say, one of the things I wanted to add to is our office does not track if they're above the age of 12, just because of the fact that we realize those kiddos are probably trying to experiment on their own. So we're not tracking that data. If this is basically those kids that need supervision by an adult. So just so you have that understanding, we know that there are other kids that are ingesting over the age of 12. We're just not tracking that data.
Yes. Thank you, Jen. And I think of note here of interest, at least to me, from my perspective, looking at our response to, maltreatment for kids, especially ingestions, but look at how many are 33 and 13 are at 1 and under, like right in that is scary. But what that tells you is these aren't the kids that are out wandering around the rooms, the bedrooms by themselves. So that means that parents are making it very accessible to children, or they're being very, very reckless with their own usage of these drugs and therefore exposing their kids to them. Because those kids aren't kids that are out rolling around, like I said, and getting into mom's bedroom. And I'm not saying that as they get older, they don't, but at that young an age, it's concerning for the level of care that those caregivers are giving. So moving along, a little bit of information about marijuana and THC. And so marijuana, again, we're going to continue to see such an uptick in marijuana ingestions with kids because we're obviously in this nation, it's becoming more and more legal. So the American Academy of Pediatrics is a great source of information. They do a lot of work at looking at trends, information, and then learning from it and farming it out to anybody in the field, especially the medical field, but even those of us doing our work. So they have the National Poison Data System to help them collect that data. And they looked at data for kids, you can see here, under the ages of 6, between 2017 and 2022. 2017, you had 30 states and the District of Columbia permitted to have medical marijuana usage, 8 states with recreational. And then we go 5 years, right? And we bump up to 39 states, medical, 18 states, recreational. So that means we're going to see an increase, again, in these ingestion cases. It is a 1,300% increase in pediatric THC exposures and ingestions. That is an astronomical increase. Now, it makes us ponder, at least if I'm looking at data, I'm always looking at all angles. Is it possible that there's a large increase, and part of that increase is because we just have a better understanding of this and we're testing more often and we're seeing clues of kids and saying, hey, I think they're symptomatic for this. And we're doing a better job at kind of identifying and then getting them tested. I'm sure that is part of it, but that's not why you have such a huge increase. It's just because in general, it is in our society more. 96, not a surprise here either, like close to 98% of these incidents occurred in the residence. And 70% of these cases included central nervous system depression. Why does that matter? Why did I include that information? Just to try and drive home at this point, our medical providers around the nation, but our care team here in Delaware, we're so blessed to have Nemours. Right in our state, they're great partners, always accessible to us in this field. And they have been sounding this alarm for quite a while. That marijuana has profound effects, or can have very profound effects on children, much more permanent effects on kids. I mean, think about it. Kids' systems, their brains, their neurological system is developing. And so something like marijuana or THC exposure can have effects on them that are more permanent, or are going to delay or cause problems with that development. It just has more profound effects on kids. And so we would be remiss, Jen and I, if we didn't say to you, pass that message along from our care team, like, we have to look at these as potential lethal situations, even with marijuana, for our kiddos that are ingesting this. And these edibles, oh boy, edibles. Adults that are okay with, marijuana, recreational marijuana consumption, think it through as it relates to children. So these edibles are marketed in brightly colored packaging. They're often packaged to resemble like name brands of candies and snacks and treats. Many of these edibles contain multiple doses. So they're created even like a cookie about this size. It's intended to be multiple doses. So adults know that you're going to eat a portion of the candy bar, portion of that cookie. You're not going to eat the whole thing. What is a kid going to do? They see a candy bar, they see a cookie, and they're going to go for the whole thing because that's what they're going to eat, like 5 if they can. Right?
Put that with the records. He has to look at them.
Right. So think about that.
And if you can make a copy of this for me, I appreciate it.
We're good. Hey, I just think we have an unmuted phone.
And I'll take them.
You don't mind checking your phones? Thank you. I know it happens. I do that too. Actually, my keyboard, I touch my keyboard for something and automatically I'm like, wait, what's happening? Why is it muting? Why is it unmuting? Where'd my video go? Yes, I totally understand. So with these edibles, because of again, they're meant to be multiple doses in a pack or in whatever that cookie, whatever that candy is. Kids don't know that. And they're ingesting a large amount of THC. Plus it's concentrated. It's concentrated amounts of THC in that edible. It's created that way. Again, why it's supposed to be a small bite of it. Adults often don't see though edibles as dangerous for youth because it's not considered dangerous for them. They're not understanding what I've just told you about them. The other component is sometimes adults also think they're safer than regular loose marijuana that you might smoke because they're thinking, well, if I'm getting the marijuana that I smoke on the street, not from a dispensary, but that I might smoke on the street, that I buy on the street, that could be laced with drugs. But an edible, I'm buying it from a store. It's not laced with anything. It's still dangerous for our kids. Still dangerous. So just some pictures. You can see here, these are all made to look just like name brands. So the Reese's are Reefers, and then the Snickers bars, THC Snickers, and the Oreos are called Stonios, and the Starburst are Starbuds. And so they look, I tell you what, they're pretty good at marketing. The Nerds rope is called a dope rope. So it's very easy for us to see why kids are so enticed with these. And if they're not put away appropriately by parents, caregivers, adults in the house, then kids are going to go right for these types of products. And they have, we've had situations where they remove them from cabinets, where they remove them from the freezer, and they eat these that, an adult was thinking, well, I put it away, it's in the freezer, but a kid, if they're in there, they're going to see that and they're going to want that. Okay, so I'm kind of taking you through like, what is that? What do we call this? How do we define the ingestion? How does it happen? A little bit about the different types of drugs and in ingestion situations in Delaware. So I'm going to hand it over to Jen, and Jen's going to talk you through, so you can see here what happens when that ingestion situation occurs, because this is what she does. She tracks this for all of us.
Yes. So obviously, when an ingestion occurs, we're hoping that the child is going to be transported either to their local emergency department, either by a parent, or sometimes they'll call 911. A lot of times it's dependent on what the symptoms that the child is displaying, right? So a parent might be like, oh, they're acting a little funny, I don't know what's going on. Or they may know that the child has gotten into something, so they may just go ahead and take their child in. Or else, the child is severely symptomatic, unresponsive, having a hard time breathing, depending on whatever's going on. And so they'll contact, 911 and actually get the kid transported via EMS. So then the child is taken to either their local ED, or else, depending again on the severity of the ingestion, they're going to either be treated right there at their local ED, or they're going to be transported by that ED up to Nemours. A lot of times they will get their preliminary urinalysis done right there at that local ED. And just to see what they're dealing with, because a lot of times these kids, they don't know it, they don't automatically suspect an ingestion right away. And depending on the story, if the parents are like, I have no idea, they're going to look at other things, such as like, did the child have some kind of traumatic fall? Is there some kind of other reason for that altered mental status? Is there a seizure going on, like a seizure disorder or something like that? So one of the things that our EDs are getting much better at is also putting into that frame of reference that this may also be an ingestion, depending on whatever story that the parents are giving. So at that point, the medical team will make the report to the DFS hotline, and the law enforcement agency will also be hopefully contacted by medical, but definitely by DFS. That's going to start that multidisciplinary team reaction. And then lastly, with these kids are transported up to Nemours, our care team, which is our child abuse pediatricians, they'll notify us at our office, the Office of the Investigation Coordinator, of the event too. We're also notified by DFS. It just depends on who gets it first, right? Sometimes DFS is out there, their boots on the ground, they're doing their thing. They're going to notify us later, where care team gets the notice, we're going to have a kid coming in right now. Hey, I see you need to be aware of this, so that we can kind of start our process of entering these kids and kind of tracking them. So basically our office, we start the process of looking at history, right? So we are going to look at the DFS history to see if there's any previous concerns with drug use, any previous concerns with any kind of abuse in the home. Basically, if everybody in the home, any family member, any caregiver, anybody that is associated with the case. We're also going to be looking at their criminal history. Are we going to look at, were they ever arrested for drugs? Do they have a known drug issue in the home? So then we're going to take all this information that we have. We have access to all the databases. We have access to DFS's focus system. That's what they call their internal system. We have access to the criminal justice system here in Delaware. So we're going to be taking all that information, and we're going to be compiling it into what we call an IC referral. So basically, this is just a summary to our frontline team about what is going on in the home. So we talk about the demographic information, who's involved, who the family members are involved, who the potential suspects are, which normally when we're looking at suspects in a home, we're looking at any adult that could be in the caregiving role in the home. So it could be mom and dad live with grandmom and grandpop, and even though they're not, grandmom and grandpop may or not use, we're going to list them as a potential suspect, because everybody in the home that could possibly be caring for these kids could potentially be a suspect. And we don't want to automatically make assumptions that, oh, it can't be grandmom, when we need our frontline staff to look at everybody in the home and what their roles were in that situation. So we're going to compile all that information, DFS history, criminal background history, and we're also going to put on there a little snapshot of just a reminder of what our current MOU practices are. So we have the Memorandum of Understanding that came out from our CAN Best Practices, which is our Child Abuse Neglect Panel that has overlooked these cases for many, many years. I don't know how many, Adrienne will be able to tell me, but they look at these cases retrospectively and see what the system did really well versus maybe some of the things that we need to work on, so that we could look at like training or things like that in the future. But out of that, all those reviews came these best practices and protocols on how we investigate drug ingestions civilly and criminally. So we just put a little snapshot on there. Not that most of these men and women are very well versed in this, but occasionally we're going to have a DFS worker who's new, or a law agency that doesn't normally take care of these kinds of cases. So we're just going to put that out there as a kind of a reminder. And so then what we do is we send that out to our team. And then what we're also going to do is we're going to be offering them an MDT meeting, a multidisciplinary team meeting. So we are going to attempt to schedule that within the first 24 to 48 hours. Although I'm sure that you guys understand that our team is very, very busy. There are always boots on the ground. There's a multitude of cases going on at any given time. So we try to do it as quickly as possible so it benefits the team. We're also taking all that information and we're entering it into our apricot system. That's our internal system, so that we are able to track these cases. Like I said, we're tracking these through the civil and the criminal investigation so that we can look at those trends. And we're looking at those cases while they're open with us monthly. So we're tracking those DFS investigations. Is there safety planning going on? Is there joint interviews going on? Is there child advocacy center interviews going on? Things like that, as well as the law enforcement response. And then, of course, we have monthly case reviews. So when these kids are being seen at the child advocacy center and have a forensic interview, they're also going to be reviewed monthly, 60 days after they have their forensic interview, until the case is closed out civilly and criminally at that review. All right, so DFS, they're going to get the hotline. They're going to complete that hotline. They're going to look at all the DFS history. They're going to put that into a snapshot for their worker. And they are also then going to go run into the emergency department. They're going to go right to the emergency department wherever that kid is. Depending on if they're at BB down south, or they're going to wait until the child is transported up to Nemours, but they're going to make an initial P1 response, which is there within 24 hours. And they are also going to be communicating with law enforcement so that they can do a joint response, because we find that when these cases come in, with all cases, that when our law enforcement agency and our DFS workers are working together, we're getting better responses, and they're getting the same story at the same time. And it's not like one of them is coming back and being like, well, what about this? What about this? They're getting the same information at exactly the same time. So criminal can do their part as far as the criminal investigation. DFS is looking at the safety piece of this. So they're doing that communication coordination. They're looking at all those things, the suspect interviews, there's sibling interviews that need to be happening. We're going to get those safety plans done, where they're going to be talking about who is in the home. Okay, well, grandma was in the home during the ingestion, so we can't utilize grandma, but do we have an aunt that wasn't in the home? Somebody else that could possibly step in it and be a safety plan participant, either supervise mom and dad's contact all the time, or sometimes we're going to have to move those kiddos out of the home. Sometimes we're going to move the parents out of the home, depending on the situation. Or unfortunately, as we're all aware, sometimes those kids are coming into care if we can't establish some kind of safety plan participant. One of the important things that you should know too is a child should not be considered safe in a hospital setting. A lot of times we're thinking, oh, well, the kid's in the hospital, they're fine. The nurses and doctors are there checking on them. And what we find is they're not safe, because they're still having that unsupervised contact with a parent. And, we can't assume that our medical providers in the hospital, they're very busy people taking care of a multitude of patients. They're not able to keep that 24-hour, observation on these kids. And unfortunately, we've had kids, not necessarily in drug ingestion, but other kids get hurt even in the hospital situation. So we always make sure that DFS has a safety plan in place even during the hospital stay. So DFS is obviously, they're looking at all kinds of things during the situation. They're looking at the safety planning. One of the things that we've also found, especially with these drug ingestions, is we want to get these siblings or any other children in the home medically evaluated, because unfortunately, as Adrienne showed in our data, we've had multiple siblings, and it's not necessarily the siblings are not always symptomatic. So we're going to have these kids come in and get examined by our EDs, and hopefully we're going to have them also have a urine screen done, because what we have found is sometimes we have one kiddo who is absolutely symptomatic and other kids that still have it in their system. Maybe we missed the window of time where they were symptomatic. Maybe they never were symptomatic. It just depends on, what their metabolism, what their exposure was. So we always want to make sure that those kids in the home are being medically evaluated. Again, they're going out and doing that joint investigation with law enforcement. They're doing home assessments. They're collecting all that collateral information, from the kids' doctors, from the schools, seeing if there's any other concerns. Did anybody else have concerns about drug use in the home? Any other concerns about domestic violence, mental health concerns, all those things that are going to look at safety concerns. And then again, we're going to have that MDT meeting. So we'll talk about that, I think, on the next slide. Correct, Adrienne? All right. So, okay. Again, law enforcement, they're going to go right out to the ED as well. They're going to check with their history. They're going to check on the criminal history. They're going to take the lead on these cases as far as those suspect interviews. DFS is going to be kind of watching in the background. They'll add their any questions they have as far as the safety planning stuff, but law enforcement is going to take the lead on these cases. And one of the things that we have found, again, with the CAN best practices MOU is the evidentiary blood draws. So it makes for a better, I guess, prosecutorial case when you have that evidentiary blood draw. We can't rely on our hospitals to do those blood draws. It's just not the same thing. It's not the same chain of custody. It's not the same. Medical providers are focusing on that medical care, right? They're focusing on what is going on with this kid and how are we best medically treating this kid. Law enforcement is looking at, I'm collecting evidence because I'm looking at this as a possible crime. So it's a completely different kind of filter. But one of the things is they're also doing those blood draws of those parents to see, especially if their impairment is suspected. If you have a parent that clearly looks like they're intoxicated or, appears to be on something, they're going to want to basically draw that line. Like, okay, well, this parent, we got the evidentiary blood draw. This parent tested positive for cocaine and fentanyl, and here this child who's the victim is also positive for cocaine and fentanyl, and maybe this other parent has nothing in their system. So again, it's a better draw. Adrienne, I know you.
Oh, sorry.
Yeah.
I'm sorry. No, before we move to the next slide, I was going to say, and the reason why with the parent or the caregiver, to make it even more, I guess, make more sense, is we have parents and caregivers that we're like, is it impairment? Is it not? They seem off. We don't know, but they're telling us, no, I have no idea how my kid got whatever the substance is in there. I don't know. I have no idea why there's fentanyl in their system. No. I mean, I did 3 years ago, but I've been clean for 3 years. And we're like, there's some impairment. And so we'll ask for consent, law enforcement will, or they can even do a search warrant. But that's why with the, the blood draws of the caregivers is then when that comes back, if indeed that caregiver that's like, no, it wasn't me. And we're like, oh my goodness, yeah, they sure are positive for this. Then does that make sense? That's why that's added evidence for, prosecution to happen if that's going to happen. So I just want to kind of drive home. It's not because we're trying to be, as a system or frontline responders, it's not as if they're trying to say like, oh, you can never forgive for substance misuse. Right. I mean, people do have substance abuse and misuse issues, and they do get clean and they move on and they're great and nothing happens. It's not because law enforcement or DFS is trying to look at them with this negative cast and that person can never lose that reputation. It's because when we have these situations, we know that parents tell us that and we're like, and then they end up being positive. So I just want to kind of clarify, it's not to try and be difficult or hold that over their head. It's because it does help us. And if they come out clean, wonderful, they came out clean, and it's never going to be they're held down. It's going to be most of them just consent. Most parents and caregivers, 98% of the time, they offer consent. There's no search warrant that even has to be obtained. So I'm sorry, Jen, I didn't mean to interrupt you. I just kind of want to make it clear because I think sometimes we come across it as a system like we're holding that against that parent that's actually trying to do better. Not at all. We love that when the parent is able to move on from that.
Absolutely. All right. So again, going into that law enforcement response, they're going to go out to the house. They're going to be doing either a consent search where they're asking the parents, hey, can I look around and see what's going on? And if the parents are obviously concerned about that, they can go and get a search warrant as needed. But they're going to look at things, is there any drug paraphernalia? Is there any evidence of any drug use in the home? Anything that would be concerning that they could see right off the top of the bat. They're going to be interviewing all the witnesses. They're also going to be participating in our MDT meetings. We are having fantastic response from all of our frontline workers, law enforcement agencies, and the prosecution to come in and listen to the medical evidence and things like that. So they're getting that firsthand. Then they're going to consult with the DOJ after they've completed their investigation and determine whether a charge is appropriate in this case. So, there's a lot of ongoing conversations between DFS, law enforcement, and the Department of Justice all throughout these cases. It's not a silo thing where they're just doing their own thing. There is a lot of joint responses going on because, again, they realize that the best outcomes for these kids and these families is when they're all communicating from jump. And just talking about child injury. So, absent good cause, our statute states that if a kid is age 3 to 12, they should be seen at the Child Advocacy Center for a forensic interview. We just know that they're better prepared. They are, that's what they do. They have all the right questions. There's no leading. It's just a better situation for those kiddos to be seen in that situation. And sometimes they'll push it. We might have a 2.5-year-old that may be able to be forensically interviewed if they're very, very verbal, or not. And sometimes we'll have, older kids that are like 13 that will still go into the CAC to have an interview. It's dependent on, whatever the law enforcement and DFS worker feels is appropriate. But those 3 to 12s, they should be seen at the CAC. And law enforcement and DFS are making that interview schedule together so that they all can be around the table when the forensic interviewer is questioning what's going on with the child. So everybody can hear what the child is saying. And then they're in the back and they're kind of meeting as a team too. Like, oh, I need to know this information. I need to know this information, so they can respond to the forensic interviewer, and the forensic interviewer can go in and kind of get those other pieces of information. Because obviously the one thing that we want to do is don't want these kids interviewed over and over and over and over again. That's very traumatic for the kid. That's when, the defense may be like, well, their story changed 5 times. And it may not be that the story was changed. It was just that different people were asking things differently. Kids are not always good, especially our younger ones, at time frames and things like that. So it's always good to have that one-time interview where we're all sitting around the table listening to the same information. And they're going to bring in like the siblings, any other children in the home as well. Again, just to get those different pieces of information, because we may have a 3-year-old that's ingested a drug and they have no idea what drugs are. They have no idea that mommy and daddy use drugs. They have no idea. But the older kids can tell us, oh yeah, I see dad doing this, or I see mom doing this. So they're going to get more of that information about what is going on in that home, what is actually happening, so that they can kind of give that background information for safety issues and for the criminal prosecution. All right, so our MDT meetings, we started MDT meetings, I want to say it's probably been about 2.5 years now. I think it's been about. So basically, once we send out that IC referral, I'm basically already asking the team when can they meet, and then we get it so we can all meet. So it's basically all of our team members. It's our DFS worker and their supervisor. It's our law enforcement agency, as far as the detective that's actually assigned. Sometimes their sergeant will sit in, depending on the agency. We have our medical team sit in, so it's either Dr. Deutsch or D. Young from our care team, as well as their care team social worker. We have the Department of Justice sit in, so it's the prosecutor actually assigned to the case, as well as they have a nurse analyst that works with them, who kind of helps them interpret all this medical evidence so that they understand, all the medical intricacies of all these cases. So sometimes we'll have other people sit in. We're going to, sometimes we'll have the child attorney sit in. Sometimes we'll have the CASA coordinator sit in. It just depends on whatever is going on with these cases. Again, we try to schedule them within 48 hours. That's the dream, right? But we also know that sometimes we have very busy people that are actually they might get 2 drug ingestions in one day, and then they've had 3 days of court. So we try to get them scheduled. I'd like to say within a week we're getting that information, because again, we want to make sure that the MDT members are getting that information right away, so that decisions are being made with all the information possible. Because again, what we were finding was, maybe our DFS worker was talking to a medical professional and heard something differently than the law enforcement, because these are big medical terms. I had to sit on these meetings literally with Google up and like phonetically type things, because I'm like, this is a big word, I have no idea what this is. So just again, to make sure that, and that the great thing about these meetings is everybody's on, and so maybe law enforcement has a question to the medical provider, about something, but DFS had that same question, and maybe they just hadn't thought about asking it, or it kind of prompts that team building, that team response, and everybody gets their answers. And we usually have one. We can have multiple meetings depending on the case circumstances. And it's not just even for our more serious cases, any case at any time. If there's a concern going on within an MDT, like DFS is like, hey, I'm just not getting a response from our law enforcement partners. Can you bring forth a meeting? I've had the care team be like, hey, this case, I have some concerns about whether DFS and law enforcement really understand what's going on here. We'll bring the team together and kind of talk through things. So it's been a fantastic result of the MDT meetings being put into place. All right, it's just back to Adrienne, because as our former DSP trooper, she can explain the prosecution a little bit more than I can. So Adrienne, it's all you.
So I'm not going to, I could talk, an attorney could talk for hours about this, but I just wanted to put a little slide in here just to kind of explain that I know that if you're not in this work, there's always the question of like, why did no arrest happen? Why is there no accountability as far as criminally? I know that, DFS continues with their civil investigation, and they certainly have different, where they can substantiate with concern, without concern, for example. But we don't often get to prosecution. And I'm not saying that we need to be prosecution happy in this state, but certainly accountability for those that cause our children harm through recklessness, negligence, or intention should have accountability. It's just plain difficult. First of all, as you saw, the age of those kids. Remember, the majority of these cases are kiddos that are young and that are at an age that's nonverbal. So even just for beyond ingestions, even just serious injury cases of any kind, it's kind of hard when your victim can't talk. I'm not saying it can't be done. We do it every day, even in adult homicides, that victim's deceased, but we still make a case. It's just that is an obstacle, and it's tough to overcome that. Just determining when the ingestion occurred, that can be tough. There's different half-lives for different medication or for different substances. And so some of them are processed fast, some are not processed fast. When you look at marijuana, someone can test positive for, the presence of THC, marijuana, and it could be 30 days later. But that doesn't mean that there can be prosecution, because you have to look at, was there a level of impairment, and what's the level where there's issues. That's still up in the air, determining with marijuana, when can it be deadly to a kid, when can it not be deadly to a kid. You can see here already, there's a bunch of different factors that create obstacles to prosecution for these types of cases. Then let's look at the fact that in these homes, the majority of the time, there's multiple individuals. Even if there's one parent in the home or one legal guardian, there's almost always other adults in that home. It might be a 19-year-old sibling. It might be an aunt, an uncle, so-and-so's sister staying there, or people are popping in and out all the time. That's really tough, because you have to determine who the person is, either intentionally gave a child a substance or negligently left that around. And so when you have multiple people, the majority of the time, people aren't going to say, yeah, it was me. They're going to say, oh, I didn't have anything to do with that. So then you're looking at, if you can't determine an exact time frame for when the ingestion happened, if the medical community can't say it had to be in the last 12 hours or it had to be in the last 6 hours, if they can't, it's kind of hard when you've got 6 different people that have rolled into that house in the last, I don't know, day and a half. So those are, quite frankly, the obstacles, right? It doesn't seem like there's a lot of obstacles, but those are huge obstacles as far as trying to overcome, the issues with getting to a successful prosecution. And so even if we have enough probable cause to make an arrest, the prosecutors, the Department of Justice, is responsible then for, getting beyond that. So for conviction, it's proof beyond a reasonable doubt. That's a tough. That's the toughest threshold to meet, well beyond preponderance of the evidence. It's a tough threshold. And so we just can't, make arrests for parents because of probable cause, but then we don't have a chance at successful prosecution. That's the other component with that criminal outcome, right? With the criminal accountability. So they just become very messy and difficult. It does not mean that there cannot be prosecution, that there can't be accountability on the criminal side with law enforcement. There can. And, going through, or when you look back at what Jen just talked about what law enforcement does, what DFS does, and then concert with the rest of the team, the evidentiary blood draws, the interviews of the siblings, getting the medical exams of the siblings, all of these best practices that were identified and then incorporated in the MOU in the last, 3, 5, 6, 7 years, those are really helping us get to the point of where we can see maybe an arrest and some prosecution and some accountability. And not because, again, it's trying to be, arrest happy. I don't want to sound that way because I'm part of law enforcement. Not at all. The goal is accountability so that someone will do differently. And typically there's going to be a history of this stuff, or it's a very egregious case of harm to the child. And so we have to have accountability for that. But there's co-occurring at the same time. I'm going to remind you that there's the civil aspect, and that is where DFS is doing all of their work to look at the totality of that child's situation. And if there is drug usage, then are we getting help? And we know they are. DFS is plugging them into services, and there has to be accountability, and that they're, getting tested, and that they're going to counseling. Otherwise, they can't have access to their child. And so it's looking at the totality, really, of the situation, not just the criminal part, but the civil side. And hopefully with those two together, we can have that level of accountability, but support and service. Just a real quick, we're right there at the end, a little reminder with our MOU and some of the guidance with these guidance for our frontline team. I just want to wrap up with some reminders. So we tell our frontline people in this MOU, which incorporated the best practices for response and investigation. The AAP recommends that every suspected ingestion case should be approached as a potential near-death incident and investigated as such. And remember, I said earlier that our care team in Delaware, our Nemours care team, our doctors and our specialist care clinic, they've been driving this home for a while. They've been sounding that alarm, and just anytime there's a frontline user, anybody that's come in contact with these types of cases, they're like, look at it as a near-death, look at it as a near-death. But the AAP does as well. At the time of this initial report, cases of ingestion or poisoning may sometimes be assumed, right, by frontline folks that they're minor, unintentional in nature, because we're trying to be forgiving. We're trying not to just be quick to judge folks, right? That's not how that's supposed to happen at the front line. So sometimes DFS and law enforcement approach those cases in a delayed manner, or they'll sometimes even tell, caregivers, hey, we know this is an accident. Don't say that. You don't know until you've investigated. You don't know until you've gone through all of those little best practice investigative measures, right? Like interviews together, and the interviews of the siblings, and the medical exams, and the evidentiary blood draws, and you've met with the medical team. You don't know that it's an accident. So it's great to keep an open mind, but don't think of it that way and then delay the response, and don't tell caregivers that, oh, it's just an accident. We don't know. It doesn't mean you can't approach with compassion again and objectivity. You do, but you have to definitely keep that to yourself about it being an accident. We remind law enforcement, you've got to get out there quickly because you need to get that evidence. We need those evidentiary blood draws. And the fact that some of these prescription meds and illicit substances are metabolized very rapidly after ingestion. So that even ups the level of urgency for law enforcement to get out there and start collecting your evidence. So just I wanted to dial down, wrap up with that little reminders that we give to our team, so you can kind of see where they're coming from when they approach these cases. Awareness, and we have quite a bit of awareness and prevention efforts. And why do we even mention this? It's not really where Jen and I work. We're in response, but I think all of us realize that to tackle this issue of child or pediatric drug ingestions or substance ingestions, it's a two-pronged response. It's, a two-pronged approach. It's how we respond to the investigation, but it's also, and medically, but it's also that prevention work. Like, let's try to stop it before it happens. It's great we're getting better at responding, but let's try to prevent it. So there is a lot of work in Delaware that is nationwide, but in Delaware that's happening. CPAC, for example, has a drug ingestion work group. They have a lot of public education efforts that are going on. And there's the representation in that work group is pulled from different medical providers, hospitals, different groups, as well as you have some from DFS. You have folks that are from, there's a couple law enforcement, educational field. You have quite a variety of different professions that are part of that group to bring their expertise. And then they'll do something as simple as signs on the buses that are buses, information to state service centers. They're working with the medical community, just with primary care providers, putting information out there, helping primary care providers to have good information to counsel their parents. They're trying to offer, special events where lock boxes are offered, right, to parents that need them to secure those prescription medications. We're working with community groups like Boys and Girls Clubs, right? How about public libraries? Our public libraries are great sources or great repositories of resources and information and projects and meetings and groups that are there. Our hospitals are offering education information for all their patients. They're trying to work on curriculum and how to educate parents, especially new parents. Think about that. Educating them about, if you're going to be breastfeeding, mama, none of this, recreational drugs that you're using. That's not going to be good. So working with them, there's much more that's happening in the prevention world, but I just want to kind of give you a little bit of a taste of what's happening, so you can know that, yeah, that's great, Adrienne, Jen, that Delaware's working really well on their response. What about preventing it? Because that's the best case scenario. If we can prevent it, we can reduce that. That's exactly what we want for our kiddos. So That brings us to the end. Do we have any questions? I will quit yammering.
That's great. You did a great job providing a lot of information in a condensed period of time. So thank you.
That's because we're fast talkers.
I love it, right? Everybody just needs to like get the information quick. Yeah, do we have any questions?
Okay.
No, that's okay.
Well, no, that's fine. And so I always leave,
I have a question. I'm sorry.
No,
Yeah,
you're
go,
good, Sherry.
go for it, Sherry.
So it seems like it does take a long time to prosecute a case for an ingestion. Is there anything that could be done, I guess, on the DFS side of things, so that, like, let's say if it was a parent or grandparent's fault that the ingestion occurred, that they maybe wouldn't be in contact with the child? Or how does that work with preventing contact with the child if something like this has happened, but they haven't, done the prosecution yet? Does that make sense?
To a certain degree, I think I somewhat understand. You're getting at the fact that and this is what our frontline team members, I'm gonna let Jen, I think, respond to them. She has a good idea, but we deal with our frontline team members all the time, and that's that DFS has a quicker timeline. First of all, they're fairly mandated, 45 days, right? And then you gotta notify perpetrators or alleged perpetrators of the allegations. And law enforcement can take a while, and for multiple reasons. There's a lot of different interviews, tracking people down. People don't want to talk to law enforcement. They're like, no, you are like the pariah. Then they're waiting for evidence to come back, and evidence has to be tested, and there's a lot of evidence backlog. So there's a long timeline, and that leaves DFS and families hanging in the balance. And so I think, Jen, I hate to put you on the spot, Jen, but I think you probably have a better perspective, especially since DFS was your wheelhouse before you were at IC.
No, I think that the DFS and law enforcement really try to work hard together to figure out who are the suspects, who can we eliminate, and what are we going to do as far as the safety planning. DFS is always talking to law enforcement about the safety plan, and we often talk about that in our multidisciplinary team meetings. They'll come in and we'll kind of discuss the case about whether a modification can be made to the safety plan. Obviously we don't want to keep children away from their families longer than we have to. I mean, we know that just leads to further trauma or whatever. But unfortunately, we also have to keep in mind that if we don't know where the exposure came from, we have to make sure that the kids are safe at the end. So, it's definitely a delicate balance, where DFS is really trying to work hard with the family. Can we keep the kids in the home? Can we keep them with a grandmom that, maybe the parents can get supervised visits, or whoever gets supervised visits. And of course we know that, obviously custody is the last resort, and when they can't get a safety plan participant, because of whatever the family's circumstances is. So I know that doesn't really answer. I think it's, it's a case by case basis, but they're always in communication as to the safety plan. And, because they're not going to modify the safety plan if law enforcement is like, wait, we're still looking at them as a suspect, or vice versa. Law enforcement doesn't want that to be a safety plan participant when they're like, wait a minute, we're not sure if they were, a possible suspect in the criminal investigation.
Can I ask a follow-up question to that?
Of course.
So if, let's say if a parent or grandparent was charged with something like that, but then they were found that they were innocent, if the child had already been taken away from them, is there anything that they could file or do to get their child back?
So the child was taken away during the investigation, but then they were no longer considered a suspect, or they were already charged?
I guess I'm saying, if they were charged, but then it went to court and then they were found innocent, but the child had already been, taken away from them, would they be able to go back and try to get their child?
I would think that that could be something that they could go through family court, and if say it was a guardianship, or even if DFS has custody. If DFS has custody, obviously you're going to be working through the case plan, and I know that I used to be a treatment worker back in the day, and even those cases would be transferred to treatment and provide those services to the parent or guardian, the parents. Even if grandmom has guardianship and they're working through that criminal piece, and maybe that the charges are dropped, we were still offering those services. They're probably going to have to come forth and show a family court judge that they've maybe completed a substance abuse evaluation, a mental health treatment, things like that, a parenting class. Even if the charges were dropped because charges may have been dropped doesn't necessarily mean something didn't happen, right? So, I mean, sometimes charges get dropped because prosecution doesn't have enough evidence to move forward or things like that. So it just depends on why those charges got dropped, because, prosecutors may not feel that they had a strong enough case, and the case, the charges may be dismissed. So it's kind of a tricky question. I don't know. I'm not exactly sure how to answer that. I hope that helps.
No, that answered it. Thank you.
Yeah. And I'm going to wrap up with, because it's a case by case thing. And so, yes, we'd like to tell you that this is going to be what could happen. This is the recourse for those grandparents or the actions they can take, but it's a case by case. But I'll say this, Sherry, we can we can take a dive in, do some inquiries. I'm happy to do that. And, I can get that information back to Lauren to get you, because I always say, even if you have a question after this, even after we wrap up today, please ask Lauren, or Lauren, you can put your email, my email. I am always happy. I don't ever want to talk with a group and then I leave questions or something comes up later and I'm not available. That's not how this works. So I'm still always available to answer questions. But Sherry, we'll look into that and see if we can't find a better answer for you. Okay.
Thank you.
Or not better, but more of an answer. Because Jen does give good answers. Sorry about that. Because
that's all right. I sound
like
a
biased. She knows her stuff. Yeah.
Awesome, everybody. Well, Adrienne and Jen, Perry, thank you so much for presenting today. I know you both have time crunches, so we're going to move on. And thank you so much for everybody who attended. You do not need to do anything for your 1 hour of training credit. I will go ahead and log that in for you because I can see everybody here. So have a wonderful day.